Good evening, all. Warm welcome to you all. So today we have presentation on the infectious disease cycle 2, presentation 7, and today's topic is on clinical significant antimicrobial interactions, which will be discussed by Dr. Aisha Sana. So we know how important it is regarding these interactions of particularly for antimicrobials. So today we'll see more on this topic. So I welcome you all for the session, and I'll give a brief introduction on the speaker. So today's speaker is Aisha Sana, Dr. Aisha Sana. She's from Aster Medcity, Cochin. So she is a clinical pharmacist from Aster Medcity, Cochin. She has over 5 years of experience in the Department of Internal Medicines, and she is involved in direct patient care and is a part of clinical team, and also she has good experience on conducting, giving talks and other CMEs. So without further delay, we'll start the session. So before we start the session, there is particular guidelines for the participants. I'll discuss one by one. So the first part is regarding the questions. So if you have any questions at the end of the session, you can post your questions here in your comment box, which will be discussed at the end of the session. And also, it is important for you to send the feedback, submit your feedback through the submit your feedback. You can click the button and send your feedback, which is important so that you will be later on if you want the certificate also. So it is important to you should give the feedback also. And regarding the participant certificates, which will be issued to you after the 14 days from the session. And if you're watching the event on the YouTube, please log into our website. So signing up to the FCP account is very important. So once you have logged into your account, you can claim the certificate after 14 days. And also you can download the slides. So presentation slides will be available as PDF, which can be downloaded from the website. Also, as said, as discussed, login is mandatory to download the file from the website. So without further delay, over to you, Dr. Aisha.
Thank you for the introduction. Good evening, all. So today we'll start with our topic on clinically significant antibiotic drug interactions. I do not have any disclosures. So we'll start with a short introduction on drug-drug interactions. Drug interactions are of two types, pharmacokinetic interactions and pharmacodynamic interactions. Pharmacokinetic interactions are those interactions where one drug alters the absorption, distribution, metabolism, or excretion of another drug. And pharmacodynamic interactions are those interactions which results in alteration of the effects. So the pharmacokinetic interactions are mainly due to the hepatic cytochrome enzymes. Based on this, there are two types. The drugs can either be enzyme inducers or enzyme inhibitors. Enzyme inducers are drugs which can increase the enzyme activity and speed up the metabolism. And enzyme inhibitors are drugs which reduces the metabolism of other drugs by inhibiting the cytochrome enzymes. Based on the drug metabolism, there are 6 main types of enzymes, and these are the cytochrome CYP1A2, 2C9, 2C19, 2D6, 2E1, and 3A4 and 5. So these are based on the pharmacokinetic interactions. Moving on, we'll see what are the pharmacodynamic interactions. These interactions occur when one drug alters the receptor binding proteins or the receptor binding properties, or they affect the sensitivity of other receptors of the drug. So they're mainly involved in the action of the drugs. So based on this, there are two types of drug interactions. Those are the synergistic interactions, that is, the combined effect of two drugs is greater than the sum of each drug's individual activity. And antagonistic interactions occurs when one drug decreases the therapeutic efficacy of the other drug. So these are the introduction of the types of drug interactions. Moving on, we'll see how the drug interactions are classified based on their severity. Based on severity, there are three types of drug interactions: minor, moderate, and major. Minor means it has limited clinical significance. Moderate interactions are interactions which will have patient effect, that is, it may deteriorate the patient condition and will require an alternate therapy or extended hospitalization. Major interactions can be life threatening and will require a medical intervention. And based on risk rating, the interactions are classified into A, B, C, D, and X. A means there is no interaction, B means there is an interaction but does not require any action, and C means this interaction will require the therapy to be monitored. D means interactions are there, but we'll have to consider therapy modification based on the clinical effect of the patient. And category X are interactions whose combination is better to be avoided. So these are the different types of interaction based on severity and risk rating. Now, after we have done with the introduction, we'll look into some really interesting case scenarios to understand the different types of drug interactions with antibiotics. First is the interaction of a drug combination that triggered to tremors. So we'll move into the drug interaction. We'll look into the case scenario first. We have a 45-year-old female patient with a history of type 2 diabetes, hypertension, and depression. And the patient had undergone surgical debridement for necrotizing fasciitis. And the tissue culture grew MRSA, and the patient was started on tab linezolid 600 mg twice daily for the MRSA following the surgery. The patient had been receiving tab, citalopram, and olanzapine for depression, cilnidipine for hypertension, and injection insulin for the diabetes. Post-operatively, after the debridement of the necrotizing fasciitis, the patient's vitals were normal, that is, the BP was at 120/80 mmHg, temperature was 37.1 degrees Celsius, and heart rate was 82 beats per minute. So these all were normal. But on day 3rd of starting linezolid after the surgery, the patient developed hot flashes, arm tremors, diaphoresis, and palpitations. Her BP and heart rate were elevated at 206/102 mmHg, and heart rate was at 112 beats per minute. So, a patient was normal after surgery, after 3 days developed all these symptoms. So, do you think this sudden onset of vital variation is due to an interaction? So, let's analyze the drug interaction of this patient. If you look into the drug interactions, there is category X interaction between citalopram and linezolid. Let's split up the drug interaction and understand its concept. Citalopram is a selective serotonin reuptake inhibitor. It is known to inhibit the reuptake of serotonin in the synapses of the neurons, which will increase the synaptic levels of this neurotransmitter. And serotonin is involved in regulating behavior, mood, memory, and gastrointestinal homeostasis. Linezolid is a synthetic oxazolidine antibiotic. It is a weak monoamino oxidase inhibitor. Serotonin is metabolized by this monoamino oxidase. So when linezolid is administered, it will when linezolid is administered, it will inhibit the monoamino oxidase, and thus the metabolism of serotonin is inhibited. So monoamino oxidase inhibitors, when combined with selective serotonin inhibitors, synaptic concentration of this serotonin will rise to a toxic level and lead to the precipitation of a syndrome called as serotonin syndrome. So what I meant is we look into the graphical representation. This is the neuron and this is the synaptic cleft. So the yellow colored neurons will have the serotonin stored in vesicle form, which is released into the synaptic cleft. And when we are administering a citalopram, that is a selective serotonin inhibitor, the reuptake of this serotonin back into the neuron is inhibited. And along with that, when we administer the antibiotic linezolid, which is a monoamino oxidase inhibitor, the metabolism of serotonin is eventually inhibited, thus rising the concentration of serotonin to toxic levels, leading to a condition called as serotonin syndrome. So let's understand the syndrome. Serotonin is a life-threatening drug-induced toxidrome which is associated with increased serotonergic activity in both the peripheral and the central nervous system. The symptoms can include changes in the mental state, dry mouth, sweating or fever, hypothermia and shock, diarrhea and nausea, tremors or reflex changes, and muscle rigidity. The management is discontinuation of the serotonergic agent, hydration and supportive care, Cases usually resolve within 24 hours of initiation of the therapy, but may require longer depending on the half-life of the offending drugs. The diagnosis is clinical, detailed history and physical examination, along with the history of the patient's use of serotonin drugs, will help in final diagnosis. There are certain diagnostic criteria which has been proposed. For example, the Hunter's serotonin toxicity criteria, Boyer's criteria for serotonin syndrome, and Sternberg's criteria. So these are a list of checklists which will help us to confirm the diagnosis. We can compare the patient's symptoms with these checklists and come to a conclusion. So that's it regarding the serotonin syndrome. Now we'll see a next interesting case of a patient which developed discoloration of urine following drug intake. We'll go into the case scenario. We have a 53-year-old male patient with CA colon, type 2 diabetes and hypertension with dyslipidemia. The patient was on IV daptomycin for infective endocarditis for the past 1 week. His medications, the other medications include insulin for diabetes, metoprolol and prazosin for hypertension, and simvastatin for dyslipidemia. While on these medications, the patient suddenly developed fever and cough and was readmitted. His chest X-ray revealed new onset bilateral infiltrates, that is, the signs of infection. The BAL was taken, which was negative for any bacterial infection, but drew their fungi as piglets. So to confirm this, the BAL galactose was done, which was above 2. His laboratory reports were total counts of 20,000, HP of 13.5, platelets of 2 lakh, and serum creatinine of 1.3 mg/5 deciliter. So after all the lab reports and imaging, the diagnosis of pulmonary aspergillosis was confirmed and he was started on tab voriconazole 200 mg twice daily for 1 day followed by 100 mg twice daily. But from the day 5 of starting tab voriconazole for the fungal infection, the patient developed generalized muscle pain along with a colored urine was observed. His CPK levels was sent and it came out to be as 10,000 units per liter, which was above the normal limits. So do you think the drug interaction has caused this patient's muscle pain and colored urine? So let's analyze the drug interactions. There is category X interaction between daptomycin and simvastatin and voriconazole. So let's pick up the drug interactions. Daptomycin is a cyclic lipopeptide bactericidal antibiotic. It is known to increase creatine phosphokinase, which can lead to muscle injury, leading to myalgias and muscle weakness in about 2 to 14% of patients. So CPK must be monitored at the beginning of the therapy, and it is weekly once in all patients who are taking the antibiotic daptomycin. Simvastatin, on the other hand, is an HMG-CoA reductase inhibitor. It is associated with an increase in CPK kinase causing myalgias and myositis. So when both these drugs are given together, it can result in a condition called as rhabdomyolysis. So what can be done when patient develops rhabdomyolysis? We have to consider suspending the statins while the patient is on injection daptomycin. But withholding statin therapy may also have negative neurologic or cardiac effects on patients, especially for patients who had a recent stroke or a recent myocardial infarction. So we cannot just hold the statin therapy. We can also consider discontinuation of daptomycin in patients with symptoms of muscle pain or weakness whose CPK levels have exceeded 10,000 units per liter, or in patients without symptoms whose CPK levels have exceeded 10 times the upper limit of normal. Moving on, like I said, simvastatin is also involved in high levels of statin induced, which can result in rhabdomyolysis. Statins undergo hepatic metabolism through the CYP450 enzyme systems. So inhibition of the CYP system by any other medication can therefore result in highly elevated plasma concentration of this simvastatin. We had also administered voriconazole for the patient. Voriconazole is a triazole antifungal. Voriconazole is metabolized by the hepatic cytochrome T2C19 enzyme, and it is also a strong inhibitor of CYP450 enzyme system. So when we administer simvastatin along with voriconazole, voriconazole will inhibit the metabolism of simvastatin, thus resulting in high concentration of simvastatin in the blood, leading to again condition called as rhabdomyolysis. So for this patient, we had given simvastatin plus voriconazole plus daptomycin, which eventually led to the condition called as rhabdomyolysis. So in this case, if we use a CYP3/4 inhibitor, which cannot be avoided, that is in the presence of fungal resistance, we have to discontinue the statin. That is, we are giving voriconazole in patient who is already on statin. You have to discontinue the statin therapy temporarily for at least 2 days before or 2 days after the antifungal treatment. You can also consider switching to another statin with less potential for a specific drug-drug interaction. So that is the story of rhabdomyolysis caused by statins, antifungal, and iodaptomycin. Moving on, we'll see a little about what is rhabdomyolysis. It is a rapid dissolution of damaged or injured skeletal muscles. There can be direct release of intracellular muscle components like myoglobin, creatine kinase, aldolase, lactate dehydrogenases, or electrolytes into the bloodstream and extracellular space. So these are excreted in the urine, resulting in urine discoloration. The condition can be asymptomatic with extreme elevation creatine kinase, with electrolyte imbalances and acute renal failure, along with disseminated intravascular coagulations. There are different causes for rhabdomyolysis. For example, traumatic injury, drugs, toxins, infection, muscle ischemia, electrolyte and metabolic disorders, genetic disorders, exertion or prolonged bed rest, neuroleptic malignant syndrome, and malignant hyperthermia. So all these conditions can result in rhabdomyolysis. That was the story of rhabdomyolysis. Next, we'll see a simple case where everything was aimed right but still missed the target. We'll go into the case scenario. The clinical pharmacist on call has received a query to analyze the medications of a neurosurgery patient who was a 61-year-old male with no comorbidities, who had persisting high fevers, chills, and worsening cough, along with increased secretions, even after administering the right antibiotic according to culture sensitivity. We look into the story of the patient. The patient was shifted out from the critical care unit following a traumatic brain injury, after which he developed fever, cough, and chills. All the relevant laboratory investigations, cultures, and imaging was ordered. The sputum culture came positive for Stenotrophomonas maltophilia, which was sensitive to minocycline. His CT test which revealed central lobular nodular opacities in the left lobule. His CRP was elevated to 101 from 50 mg per liter. Total counts were elevated to 20 from 12.5, all suggestive of an active infection. So the stories, we have a neurosurgery patient who had been shifted out from the ICU but developed a chest infection, and the cancer came out from Stenotrophomonas. So we have to treat the infection caused by Stenotrophomonas maltophilia. And the sensitivity was shown to be to minocycline. So he was started on tap minocycline 200 mg twice daily, along with other supportive medications like salbutamol inhalation, IV pantoprazole, a calcium-containing antacid syrup, an antitussive containing chlorpheniramine, levopropofuscin, and injection levetiracetam for the traumatic brain injury from the neurosurgery side. But in spite of giving all the necessary antibiotic, the patient still developed fever, chills, and worsening cough. That is, the patient did not improve in spite of giving the correct antibiotic. So why do you think the antibiotic is not effective for this patient? We look into the interaction. There is a category D interaction between calcium-containing antacids and minocycline. Let's split up the interaction. Minocycline is a tetracycline antibiotic. Tetracyclines have a high affinity to form chelates with polyvalent metallic cations such as iron, aluminium, magnesium, and calcium. Tetracycline metal complex is either insoluble or poorly absorbed from the GI tract. So when you're giving antacids like calcium-containing antacids, these antacids significantly reduce the absorption of tetracyclines, possibly resulting in subtherapeutic serum antibiotic concentration. And dairy products, antacids, iron salts might interfere with the absorption by up to 90% or even more. So for this patient, we were giving antibiotic linezolid for the infection, but along with that, we also gave an antacid syrup. So as a result, the minocycline was not absorbed from the GI tract, resulting in subtherapeutic concentration, and hence that is why the patient continued to have fever and chills. So if you stop or change the antacid to another drug, the antibiotic will be effective. So a time interval of minimum 2 hours should be considered between antacids intake and the administration of other medicinal product to avoid this condition. That was the story of time-dependent drug interactions. Now we'll see a case of shock waves. Let's move on to the drug interaction. We have a 58-year-old female currently admitted in a tertiary care center for pyelonephritis. and the patient was on injection imipenem cilastatin 500 mg 6 hourly for the past 5 days. The patient suddenly developed generalized tonic-clonic seizures. So we have a patient who has a complicated UTI and his patient is on imipenem cilastatin for the UTI. The patient suddenly developed seizures. The patient is also a known case of on seizure disorder for the past few years. The patient was on valproic acid 250 mg twice daily. And patient also hypertensive and anemic and on regular medication. It was found that the patient's seizure condition had been stabilized by the valproic therapy and there had been no change in the dose over past 3 years. The other medication the patient was taking include amlodipine, injection pantoprazole, calcium carbonate twice daily, and ferrous fumarate once daily. Due to unexplained sudden onset seizure, the serum valproate levels were ordered, which came out to be at 51 micromoles per liter. A serum valproate level which was not obtained on admission, but a detailed history revealed the serum valproate levels she took 7 weeks ago was normal at 536. So here we have a patient who has a complicated UTI and a known case of seizure disorder suddenly developed a seizure outbreak. So do you think the sudden onset of seizure outbreak for a normal stabilized patient is due to a drug interaction? So let's analyze the drug interaction. There is a category D interaction between imipenem cilastatin and valproic acid derivatives. If you look into the drug interactions, imipenem cilastatin is a beta-lactam carbapenem antibiotic. It is highly epileptogenic. The beta-lactam ring in this imipenem is similar to the structure of GABA aminobutyric acid, that is GABA, which is an inhibitory neurotransmitter, resulting in the imipenem will mimic the GABA and inhibit the GABA, resulting in antagonism of the GABA receptor, leading to an increased membrane potential and excitatory state that may readily depolarize and respond to stimuli, triggering a seizure attack. So risk factor for this is high dose of antibiotic, renal dysfunction, pre-existing CNS abnormalities, or a seizure history. So the patient already has a seizure history. So when we are administering imipenem cilastatin along with sodium valproate, what happens is carbapenem reduces the concentration of valproic acid. So imipenem will reduce the concentration of valproic acid in almost 90% of patients. Carbapenems accelerate the metabolism of valproic acid. That is, it accelerates the glucuronation of valproic acid to valproic acid glucuronate and inhibits the hydrolysis of valproic acid glucuronate back to the VP by inhibiting the enzyme. So when you're administering carbapenem along with sodium valproate, the concentration of sodium valproate will reduce due to increased metabolism, resulting in seizure outbreaks. So what can be done is therapeutic drug monitoring of the valproic acid concentration is necessary whenever we're giving a carbapenem antibiotic. We can also try alternative antibiotic if feasible. For example, based on the culture sensitivity, you can give antibiotics like Zavicefta or Astrana. You can also add an adjuvant anti-epileptic drug which is better for the patient, which has less seizure potential and drug interactions. So that was the story of drug interactions based on carbapenems. Now we'll next see the case scenario of an unexpected embolism. So we'll move into the case scenario. We have a 47-year-old male who is presented with the emergency department with dyspnea, chest pain, together with pain and swelling in both legs. So if you look into the history, the patient had a mechanical valve replacement 1 year ago and is on anticoagulation with warfarin 2 mg daily. He was diagnosed with pulmonary TB 1 month ago and has been started on ATT, that is isoniazid, rifampicin, pyrazinamide, ethambutol. The patient is also a known case of diabetes on sitagliptin, metformin, and is also on pyridoxine and rabeprazole once daily. On arrival, the patient's vital signs were an arterial pressure of 60/30, heart rate of 138, respiratory rate of 30, and oxygen saturation of 60%. A CT chest revealed thrombus of the right pulmonary artery and its segmental branches. An INR was obtained, which was at 0.8. So here we have a patient who is a known case of mechanical valve replacement who was on active anticoagulation and the patient developed pulmonary TB and he was started on ATT. But later on, what happened is the patient developed a pulmonary embolism. So do you think this development of pulmonary embolism is due to a drug interaction? So if you look into the interaction, there is a category interaction between rifampicin, isoniazid, pyrazinamide, and the anticoagulant warfarin the patient is on. Warfarin is a vitamin K dependent anticoagulant. Warfarin is a common derivative used to prevent and treat thromboembolic disorders. Warfarin accumulates in the liver as the RNS enantiomers and is metabolized by the CYP enzymes. And rifampicin is an antitubercular agent. So rifampicin is known to induce hydroxylated cytochrome P450 enzyme, which will accelerate the metabolism of warfarin, thus reducing the coagulation effect of warfarin. So what happened was when when the patient was already on anticoagulants and the patient started ATT, the ATT drug accelerates the metabolism of anticoagulation, resulting in the increased risk of embolism. So whenever a patient who is on anticoagulant who started on INTT, the dose of the anticoagulant must be increased and to be reduced after discontinuation of the ATT drug to obtain the target INR. Patients should also be monitored at least weekly once after stopping the rifampicin until the maintenance dose of warfarin is attained. So that was a simple, short story of ATT and anticoagulation. Next, we'll see a case scenario of heart rates. We have a 58-year-old female patient who is a known case of CAD, hypertension, and AF on tab aspirin, atorvastatin, and cilnidipine, along with tab amiodarone for AF. The patient was on apixaban 5 mg twice daily, and the patient developed urinary tract infection when it was and was started on tab levofloxacin 750 mg once daily. On day 4 of starting the antibiotic, the patient developed vulvovaginal candidiasis and the gynecologist advised a start dose of fluconazole 400 mg, which was administered immediately. The baseline ECG was taken on admission was normal, but the clinical pharmacist suggested to repeat an ECG to look for any QT prolongation, which came out to be at 460 milliseconds. That is, the patient developed a QT prolongation after administering fluconazole. So, what was the risk factor for this patient to develop a QT prolongation? If you look into the common risk factors for QT prolongation, one is female sex, hypokalemia, hypomagnesemia, hypocalcemia, bradycardia, recent conversion from AF, cardiac heart failure or left ventricular failure, baseline QT prolongation, pharmacokinetic drug interactions, and pharmacodynamic drug interactions. So these are the conditions which can increase the risk factors for QT prolongation. So for this patient, if you look into the interaction, there is a category X interaction between amiodarone and levofloxacin and amiodarone and fluconazole. Amiodarone is an antiarrhythmic and it is administered along with levofloxacin. Levofloxacin has a potential to induce QT prolongation due to reduction in the rapid component of delayed rectifier potassium current. And fluconazole, amiodarone is metabolized by cytochrome 3A4 and fluconazole is an inhibitor of 3A4. So if you administer fluconazole along with amiodarone, it will inhibit the concentration of amiodarone, resulting in a condition called QT prolongation, that is more than 450 milliseconds in male and more than 470 milliseconds in females. So this patient was administered with who was already on amiodarone for AF, was given levofloxacin for UTI and candidiasis. The patient was given with fluconazole, resulting in QT prolongation. So those were the different case scenarios which helped it to understand between the antibiotic drug interactions. Now we look into the literature and identify some different drug interactions which are rare but really serious and critical. First one is the effect of flucloxacin on tacrolimus. It was found that treatment with flucloxacin was associated with a median decrease of tacrolimus levels by 37.5%. Flucloxacin activates the nuclear hormone pregnant X receptor, which will induce the expression of both cytochrome 3A4 and P-glycoprotein. So, flucloxacin, which is known to accelerate the metabolism of these two. So, tacrolimus are metabolized by the enzyme cytochrome P450 and is also a substrate of glycoprotein. So, when these both are administered together, the effect of tacrolimus decreases. Next is a report on the pharmacokinetic interaction between methotrexate and piperacillin tazobactam. Methotrexate is eliminated unchanged in urine by glomerular filtration and proximal tubular transport. But Patients who are taking methotrexate along with piperacillin tazobactam, it is known that piperacillin tazobactam reduces the renal excretion of methotrexate, resulting in prolonged or toxic concentration of methotrexate in the blood, leading to toxic effects. Next is the study on the fatal interaction between clarithromycin and colchicine in patients with renal insufficiency. Macrolide antibiotics like clarithromycins are substrate for the cytochrome P450 enzymes and CYP3A4 enzymes, and is also inhibitors of the glycoprotein transport system. Colchicine is metabolized by these enzyme systems. That is, macrolides inhibit the P450 and glycoprotein, and colchicine is metabolized by these enzyme systems. So what happens is when you're administering antibiotics like macrolides along with colchicine, the metabolism of colchicine is inhibited, resulting in high concentration of colchicine in the blood, which can be manifested as gastrointestinal symptoms, abdominal pain, vomiting, like abdominal pain and vomiting and diarrhea, fever, and pancytopenia. Under normal circumstances, the excretion of colchicine in the urine could increase to compensate for reduced liver metabolism in patients with liver disease or to counteract the effects of administration of drug that interact with the cytochrome P450 enzyme. But in patients who have a renal insufficiency, all this compensatory mechanism does not work. So results in the accumulation of colchicine in the blood, leading to toxic outcomes. Next is the report on cotrimoxazole administered along with inhibitors of renin-angiotensin system. Trimethoprim has structural and pharmacological similarity to potassium-sparing diuretic amyloid. At doses used in clinical practice, trimethoprim blocks the epithelium sodium channel in the distal nephron, impairing renal potassium elimination. Approximately 80% of patients receiving cotrimoxazole develops increased in serum potassium concentration of at least 0.36 milliequivalents, and 6% of patients develop frank hyperkalemia, that is above 5.4 milliequivalents. But use of cotrimoxazole with angiotensin converting enzyme inhibitors or angiotensin receptor blockers results in almost seven-fold increase in risk of hyperkalemia, as already the ARBs and ACIs are known to increase potassium. Results in hospital admission or toxic outcomes. So those were a few examples of rare but serious case drug interactions with antibiotics. Now, so far we have seen negative impacts of drug interactions with antibiotics. Let's look into some positive outcome of drug interactions due to the antibiotics resulting in positive patient outcome. So these are called synergistic interactions, and it becomes the antibiotic synergism. First, we look into the famous trimethoprim and sulfamethoxazole. This is an example of synergistic drug interaction. We all know that bacteria produces folic acid for its survival. So folic acid is produced as a cofactor to synthesis the bacterial thymidine, purine, and DNase. The mechanism of trimethoprim and sulfamethoxazole is it inhibits the bacterial synthesis of tetrahydrofolic acid. That is a physiologically active form of folic acid. So this is the bacterial cell wall. In this, you can see the cycle of conversion of the para-aminobenzoic acid plus steroidine to the tetrahydrofolic acid in the bacterial cell wall. So it begins with the conversion of the PABA into the dihydrothyroic acid by the enzyme dihydrothyroid synthase, and the antibiotic sulfamethoxazole is responsible for inhibiting this mechanism of conversion into dihydrothyroic acid. On the other hand, the antibiotic trimethoprim is involved in the inhibition of this step of converting dihydrofolic acid into the tetrahydrofolic acid. So both these antibiotics act on the same cycle of converting the para-aminobenzoic acid into tetrahydrofolic acid. So if you are administering both these antibiotics together, it will enhance the properties of inhibiting the bacterial folic acid synthesis. So there's a sequential blockade of two enzymes in one pathway, resulting in effective bactericidal action and preventing the development of bacterial resistance to either component alone. So this is called antibiotic synergism. Next, we'll see the example of antibiotic synergism with the famous astronome plus ceftazidime avibactam combination, which is most recently used for resistant gram-negative infections. Ceftazidime avibactam is a third-generation cephalosporin and with a novel beta-lactamase inhibitor avibactam. Astronome, on the other hand, is a beta-lactam antibiotic of the monobactam class. Avibactam is a beta-lactamase inhibitor that protects ceftazidime from being hydrolyzed by the serine beta-lactamases, external spectrum beta-lactamases, Klebsiella pneumoconinases, and OXA48-like enzymes. But the albactam is not active against the enzymes like new-denylate metallobeta-lactamase, that is NDM, and other metallobeta-lactamases. So albactam is active against DSBL, Klebsiella, KPC, OXA48-like, but it is inactive against the NDM and MBL. So we have the astronome, which is an active gram-negative, which is active against most of the gram-negative pathogens due to its potent and specific binding for penicillin binding proteins. And it is also effective against enterobacteria with the NDM carboninases. It is unlike the embactum, astronome is active against the NDM. It is not hydrolyzed by MBLs, but it is hydrolyzed by the serine beta-lactamases, and hence it is ineffective alone as a monotherapy. So, if the resistant mechanism of ceftazidime avibactam is due to the serine and the NDL co-production, the synergism of giving ceftazidime avibactam along with the astronome can be used as a combination therapy with positive clinical outcomes. So, this is another example of antibiotic synergism. So, that's it for the presentation. Next, we'll look into the take-home messages. So ensure you have a full drug of history. Ensure you have a full drug history, including over-the-counter drugs, and analyze the drug interactions with the medications recently prescribed. Drug interactions will also be analyzed whenever a new drug is added. Polypharmacy in geriatric patients increases the risk of drug interactions. Significance of drug interactions also depends on the therapeutic window of the drugs. Drugs with a narrow therapeutic window can precipitate a clinically significant interaction, while drugs with a wide margin of safety will have minimal clinical consequences. Pharmacokinetic drug interactions can be predicted from the knowledge of metabolic pathway, and pharmacodynamic interactions can be assessed by deeper understanding of the mechanism of action of the drugs. And ensure to analyze the drug interaction through standard drug interaction references. These are the references. So that's it for today's presentations. We also have a bundle of interesting topics coming up. Next one is the topic from the Infectious Disease Forum on penetration of antibiotic to different body sites. It is scheduled on May 5th, 2024, Sunday, from 11 a.m. to 12 p.m. And we also have another interesting talk from the Critical Care Forum on topics on top papers in critical care medicine, which is scheduled on May 8, 24, Wednesday, from 5 to 6 p.m. Thank you.
Thank you, Dr. Aisha. So, neatly explain what are the severities and categories of drug interactions, when to take decisions. And I guess most of our students from in this session can benefit. Uh, they can obviously correlate with their syllabuses. So all these enzymes, everything they can know how clinically significant all these enzymes and how it can impact in our drug interactions part. So what are the X category, D category, and all. So as you discussed this, there are certain drugs which you listed, like for example, linazolids. So these drugs used to give me headaches all the time when I practice in critical care and all. So linazolid mainly it caused a lot of problem, especially with this, as you told, serotonin syndrome, all this stuff. So that was like helpful from this session, like also. And the next thing is rhabdomyolysis and also hyperkalemia. So all these parts are very crucial, especially for those practicing in critical care. You know how serious these complications can be. So I have few questions to you from my part. Like moving on, like first question is like in case of identifying the category X interactions, so how will you intervene if both the offending drugs are essential? for the patient. So how can we take a decision on such type of interactions?
The decisions basically on the clinical effect of the patient. We have to understand the clinical scenario. For example, if the patient is on, we have started the patient on a new antibiotic and this patient already taking, for example, SSRI. The current situation is when the patient requires the antibiotic for the infection. So we cannot change the antibiotic. Maybe if the antibiotic can be resistant or they can be serious infection like MRS infection. So instead of thinking of stopping the antibiotic abruptly, you can look into the psychiatric side of the patient, talk to the psychiatrist, consider changing the antipsychotic medication to another drug which is more offending to the patient. So we have to always analyze the risk benefit ratio of the offending drug. So directly stopping the new drug added. Sometimes if you have an alternative to give an alternative antibiotic for the patient, that will also be a better idea. So you have to always consider both ways and which will be more beneficial for the patient. So that will be done.
Yeah, exactly. Thank you. And one more thing, like, what are the practical skills of identifying drug interactions clinically?
One thing is proper medication history is very important. Whenever the patient is admitted, either critical and non-critical, it is very important to reconsider the patient. You need to list of all the medicine the patient was taking prior to admission. And then that's the first thing. Then you have to analyze all the medication the patient has, the new medication the patient has been currently added on. So you can analyze the drug interaction based on that. Then you have to clinically observe the patients. You have to look into the vitals, heart rate, BP, temperature, and saturation. All these are signs, all these are beneficial to understand the clinical status of the patient. Then if you are looking for other systemic symptoms like tremors, sweating, all this can give us clues to identify different drug interactions. So observation of the patient is very important. The detailed history is very important. Sometimes a patient who have been recently started on medication will develop sudden onset of disorientation or mental symptoms symptoms can reduce. So this disorientations can also be due to any drug that is offending. We have to add some drugs are neurotoxic, so we have added drugs which can inhibit the metabolism and increase the concentration of this neurotoxic drug. That is why the patient clinical neurological functioning might have deteriorated. So it is always important to observe the patient on a daily basis for new symptoms. It might not always be the condition. It is causing the new symptom or the disorientation. Can also be drugs that has been added. So observation is very important. Detailed history is very important.
Thank you, Dr. Aisha. So I guess that's it. No questions from the participant side. And I thank FCPI for this opportunity. And also looking forward to the next sessions as mentioned. So I guess everyone had benefited from the sessions regarding the interactions part. So once again, thank you, Dr. Aisha Sana. So I
Thank
guess
you.
that's it. I'll wind it off. Myself, Mohammed.